Hello, my name is Matthew Maher. I'm going to be talking to you about congenital coronary artery abnormalities. But first, I want to talk a little bit about sudden cardiac death. It is a leading cause of death in young athletes, and it occurs during an athletic event or training. Some types are HOCM, or hypertrophic cardiomyopathy. It's the most common cause. And then there's congenital coronary artery anomalies, which is the second most causes of death. And then there's Marfan syndrome, ARVD, myocarditis, Wolff-Parkinson's-White syndrome, commotio cordis, and congenital long QT syndrome. So what is congenital coronary artery anomalies or abnormalities? It is a defect in one or more of the coronary arteries of the heart. It's congenital, which means a defect or is present at birth. It can also be defected by abnormal size or shape of the coronary arteries. It is also found in patients or people with other congenital artery diseases. So what are the causes of this disease? They don't know exactly what causes it, but there are a lot of steps in the development of the coronary arteries in the fetal heart. If something goes wrong during any of these steps, it can lead to a coronary artery abnormality, and they are known to be genetic and run in the family as well. It is found in 5% of the people who undergo a cardiac catheterization. See if they have any chest pain as well. So, what are some risks of this disease? Since the coronary arteries deliver oxygen-rich blood to the heart muscle, a defect can reduce the amount of oxygen and nutrients that the heart receives, which can lead to a myocardial infarction or MI. Athletes or people who take part in strenuous activity are especially at risk for sudden cardiac death if they have a coronary artery anomaly. Like I said before, it's the second leading cause of death in young athletes. Between 15 and 34% of young people who experience sudden cardiac death are later found to have a coronary artery anomaly. So what are some of the symptoms of this disease? So symptoms begin in early childhood or others in adulthood. So for babies, they have breathing problems, pale skin, poor feeding, and they sweat. For teens and adults, they faint during strenuous exercise, they have shortness of breath at rest or exercise, or fatigue, they have chest pain at rest and during exercise as well. So how is it diagnosed? Doctors perform a physical examination and listen to the heart and lungs using a stethoscope like a regular physical. And other tests include echocardiograph, MRI, angiograph, CT, or nuclear imaging tests. So what is the treatment for this disease? So first off, you gotta make some lifestyle changes. You have to be less physically active, avoid exercising too much, and playing certain sports. Medicines, they have to take beta blockers, diuretics, and oxygen therapy as well. And then they use precautionary coronary interventions. So they're placing a stent in the artery with coronary artery abnormalities. Surgery they could get depends on the type to correct the problem as well. So the first article I'm going to talk about, it's from the American College of Chest Physicians. It's from July 1998. So the title is called In Vivo Detection of Coronary Artery Abnormalities in Asymptomatic Athletes by Echocardiograph. It's by Paolo Zeppoli from Italy. So the purpose was to assess the efficiency of an echocardiograph in the screening of coronary artery abnormalities. So what they did, the design. So they assessed the ostia and the first tracts of the coronary arteries of 3,650 subjects. So the average age of these subjects were 30 years old. All these subjects played different sports at different competitive levels and underwent a two-dimensional echocardiograph. So, what the study came up with the results. So 96% of the subjects followed up with the echocardiograph, and 90% had a clear visualization of the ostia and first tracts of both coronary arteries. But there were 3 asymptomatic athletes, which is 0.09% of the study, who had a coronary artery abnormality. 2 had a right coronary artery anomaly in that origin, and then from the left sinus, and then 1 had a left coronary artery origin from the right sinus. This study concluded that coronary artery abnormalities are rare in asymptomatic athletes, but can be identified through an accurate exploration of coronary anatomy by an echocardiograph. So the second study I want to talk about was called The Clinical Profile of Congenital Coronary Artery Anomalies with the Origin from the Wrong Aortic Sinus, Leading to Sudden Cardiac Death in Young Competitive Athletes. It is from the Journal of American College of Cardiology, and the main author was Christina Basso. So the purpose was to characterize the clinical profile and identify markers that can enable detection during life of coronary artery origin from the wrong aortic sinus in young competitive athletes. So, the methods. They use 2 large registries. So they use one from Minneapolis and one from Italy, comprised of young competitive athletes who suddenly died. So they used 27 subjects who had sudden cardiac death from a congenital coronary anomaly characterized by wrong aortic sinus origin. So they had 22 men, 5 women. They ranged from 9 to 32 years old. They either had a left coronary artery issue or a right coronary artery issue. They either had a sign of angina or syncope as well. These athletes competed from junior high to high school to college to the professional level. Each athlete died during intense exertion on the field. So 16 were in training, 11 were in competition. 15 athletes had no cardiovascular testing done during life, while 12 had clinical data available for this study. 10 athletes had symptoms before death, and none of them had a family history of cardiovascular disease. Each heart was characterized by both an accurate angle takeoff of the anomalous coronary artery with a slit-like lumen at its point of origin from the wrong aortic sinus between the aorta and the pulmonary trunk. ECG stress tests were available for some athletes, but all of them were on normal range and limits that they know of. So what did they find in this study? So young athletes with wrong aortic sinus, they found that standard testing with ECGs under resting or exercise conditions can provide clinical evidence of a myocardial infarction and was not reliable as screening tests. They also found premonitory cardiac symptoms occurred shortly before death, which suggests that a history of exertional syncope or chest pain required exclusion of the anomaly. They also found that clinical markers of the exertional syncope / chest pain can be suspected with a non-invasive ECG. And a wrong sinus can be surgically treated and identified if a person should be excluded from intense competition. So that's the end of my presentation, and I hope you guys learned a little something about coronary artery abnormalities in athletes, and I hope this stuff was useful for your own knowledge. All right.